Let's talk about colon cancer screening. Unfortunately, colon cancer is on the rise, and I see so many patients, whether it's in the urgent clinic or as a hospitalist, who have no idea if they've been screened for colon cancer, what that actually entails, what kind of tests they need, what signs and symptoms they should be looking for. So, we're going to discuss all that today, and hopefully, you learn and you can seek out screening if you're not already caught up, or keep an eye on it if you're coming due. So, colorectal cancer is going to include cancers that begin either in the colon or the rectum, as it sounds like, and a lot of them develop from abnormal growths called polyps. Some polyps might never become cancer, they're just benign, is what it's called. So, benign polyps are not cancer, they won't become cancer, but there are certain types that will gradually develop into cancer. So, if this is your colon here and this is a polyp, that's essentially what we're talking about. Now, the point of screening is that we want to find the cancer before it starts causing symptoms, when treatment is more likely to be successful. And that's the point of colon cancer screening, is to hopefully catch these cancerous polyps or even precancerous polyps and remove them before the cancer even develops at all. So just to give you some context as far as how important screening is and how important it is to catch these cancers early, in 2026, based on the data, there's going to be about 25,000 Canadians diagnosed with colorectal cancer. And based on averages and the current data, 9,200 of them will die from it. And those outcomes are going to vary dramatically by the stage of that cancer. So for stage 1 cancer, cancer that we're catching early, the 5-year survival rate is 91 to 92%, compared to only 11 to 13% for stage 4. And this massive difference is the reason why screening is so important. Now, a key thing to keep in mind is that screening does not mean investigation. Screening is for people who are already feeling well, they don't have any signs or symptoms suggesting colorectal cancer. Investigating is when you're looking for that cancer or something being wrong because somebody's already having symptoms. And these are some of the symptoms that we worry about. If you're having any of this, you should speak to your doctor and get underway investigating. At this point, you're no longer screening. If you're having visible blood in the stool, if you have unexplained iron deficiency anemia, if you have a change in your bowel habit, so normally you go once a day and it's fairly solid, but now you're having diarrhea 3 times a day, and that's been going on for several weeks, or you're going from looser stool to more firm, any kind of change like that on a persistent basis is worthwhile investigating. Any unexplained weight loss, fevers, night sweats, abdominal discomfort without a certain cause. If you have any of this or other symptoms, then like I said, now we're not screening, we're actively looking for what's wrong and what's causing this. And it may be cancer, not always, but these are the certain alarm bells that you should look for to get more prompt investigations. And likely, if you're having any of that stuff, you're going to need a colonoscopy. Now, in people that are feeling well, they don't have any symptoms. Let's talk about average risk screening. So first off, average risk, that just means, obviously you don't have any of those symptoms. You don't have a family history of colon cancer. You're just literally average risk. There's no risk factors that would predispose you to a higher risk of cancer. So in Ontario, Canada, that screening is going to be ages 45 through 74, and it's going to happen with a FIT test, which we'll talk about. And that'll be every 2 years. So you're going to receive a letter in the mail if you're a citizen of Ontario telling you that you're due for a FIT test. You go to your doctor, they order it for you. Some places send the kit directly to you. Other places you just go to the lab for most places and pick up the kit there. You're going to follow the instructions. Basically, you're going to give the lab a stool sample and they'll send it off for you. And that'll be 45 through 74 every 2 years. Now, after 74, so between 75 and 85, you can consider screening. It just depends on a case-by-case basis, depending on someone's overall health, previous screening, if there were any abnormalities, their life expectancy, and most importantly, whether the person actually wants to do it or not. There's no point in screening if a positive result won't lead to a difference, meaning if somebody were to theoretically have colon cancer, but they're not interested in treatment, they feel like they've lived a good long life, they don't want to go through surgery or chemo or biopsies, whatever, then there's no point bothering putting them through a screening. After 85, there's really no evidence to suggest that screening is valuable, at least not in Canada. And at this point, the Canadian Cancer Society recommends a stool test every 2 years from 45 to 74, who again are average risk, not at high risk. Some programs across Canada might still be age 50 to 74, which is what it used to be, but because colon cancer has been on the rise, most places are going to start at 45 to try and catch some more of those early cases or those precancerous polyps. Now in the US, it's quite similar, but they just have a little bit more variability. So the US Preventative Services Task Force recommends from 45 to 49. It is generally recommended. That's based on grade B evidence, whereas 50 to 75 is strongly recommended, and that's based on grade A evidence. So again, that reflects sort of the more recent evidence to do early screening. And then again, similar to Canada, 76 to 85 is selective, just varies individual to individual and what their goals are. So very similar across both. So again, it's important to recognize why the starting age moved from 50 to 45. The reason is that overall colorectal cancer rates have been declining over time, and screening is one of the reasons for that progress. But at the same time, it's been increasing among younger adults. So that's why the hope is that based on the current data and the current research, that starting screening earlier may lead to, again, removing those precancerous polyps before they become cancer, or finding it when it's an early cancer and more treatable. Now, another important thing to understand is, what does average risk actually mean? So generally speaking, an average risk person is somebody who doesn't have those symptoms we spoke about earlier, the bleeding, the fevers, the abdominal pain, the change in bowel habit. They've obviously never had colorectal cancer. They don't have a history of precancerous polyps on previous investigations. They don't have any GI conditions like Crohn's or ulcerative colitis. They don't have a family history. Each place is going to vary on what's considered average risk. So that's a conversation worth having with your doctor, especially if you do have any kind of family history of colon cancer or GI issues. Now let's talk a little bit more about the FIT test. Like we mentioned earlier, this is the main test that's going to be used for screening, at least in Canada. It's the fecal immunochemical test. And basically the function of this test is you drop off a stool sample at the lab, they send it off for you, and what they're looking for is trace amounts of blood in that stool that you can't necessarily see with the eyes. And again, this is going to be done every 2 years. And the reason is because one FIT test is just a snapshot in time, right? So some cancers and polyps, they're not going to be bleeding all the time. So you might have a normal test the first time, but that doesn't necessarily mean that you don't have bleeding present in general. So the benefit truly comes from staying consistent with screening and repeating it every 2 years within that screening window. So an abnormal test just means that there was blood detected in that sample. Again, that does not definitely mean that the person has cancer. There's lots of different reasons for bleeding in the stool, but that is what defines an abnormal FIT test. The blood can be from a cancer, it can be from a simple polyp, it can be from a hemorrhoid, so don't be alarmed if you get a positive FIT test back, but it does require further workup. And that further workup is going to be a colonoscopy. So either with a gastroenterologist or a general surgeon, your doctor will make a referral, and they will go in with a camera and try and find the source of that bleeding. And the colonoscopy is a much more specific test where the surgeon or the operator can literally see whether there's a polyp or a hemorrhoid or whatever is causing the bleeding. It's more specific than the FIT test. And that begs the question, why don't we just do a colonoscopy for everybody? And the reason is because, like with any other procedure, there's risks and benefits. With the colonoscopy, you're going to be doing bowel preparation. People can get dehydrated with this. It's going to involve sedation, which has its own risks. It's going to cost a lot more in healthcare resources. There's the risk of bleeding and perforation of the bowel. And as you're older and more medically complex, these risks go up. And that's why as a screening test, the FIT is a better test. But again, once we're going on to the investigation portion of things, then you want to do a colonoscopy. They can go in, they can check with the camera, where's that bleeding coming from? If they see anything abnormal, they're going to take tissue samples called biopsies and send those off to the lab to see what that tissue actually is. Is it just a benign polyp? Is it a cancer? That colonoscopy and the biopsies are going to give more answers than just, is there bleeding or is there not bleeding? Now in the US, things are a little bit different. There's a more broad menu of options, so to speak. So the US Preventative Services Task Force, they recognize several strategies for average risk adults, which includes doing a FIT test every year. It's the exact same test that we spoke about previously. There's high sensitivity biochemical stool testing, stool DNA FIT test, which is a little bit different than the traditional FIT test, a CT colonography every 5 years, which is a less invasive version of a colonoscopy, but also not quite as accurate. That's why they're listing it every 5 years rather than every 10 years like a colonoscopy. A flexible sigmoidoscopy is essentially the same idea as a colonoscopy. They're going in with a camera, but they're not going as far as they do with the colonoscopy. The American College of Gastroenterology considers an annual FIT test along with a colonoscopy every 10 years the best primary screening methods as of now. And they more so recommend the other methods when a person's unable or unwilling to get those tests done. The American Cancer Society recommends the stool DNA test and some stool RNA tests, which are newer, and these can be done every 3 years. So these are conversations to have with your doctor to see what's available to you and what the best option is for you based on your risk profile, affordability, and comorbidities. But just keep in mind, out of all these options, the ultimate test is the colonoscopy. If you do anything else and it's abnormal, The final definitive thing is the colonoscopy and the biopsies that it produces to give you that most accurate answer. So we mentioned briefly about those blood DNA and RNA tests that are mostly being offered in the States. Now, basically what they're doing is they're looking for cancer-associated material that might be circulating in the bloodstream, and they sound pretty appealing. You don't need to do bowel prep, no stool collection, no procedure, and the risks that that carries. But convenience does not mean the same thing as effectiveness. So the American Cancer Society, they don't consider those blood tests as the top-level option. It's still the FIT and the colonoscopies and those other things that we talked about. These are mainly offered to people who either decline or fail to complete those other tests. These blood tests are going to be less effective at finding precancerous lesions, which is going to limit their ability as a screening tool. And even if they are abnormal, again, it's still going to require colonoscopy to confirm that diagnosis. So think of the blood test, at least for now, as a potential fallback for somebody who might not be a candidate or they don't want to do the stool-based test or the scopes. Now, so far, we've just been talking about average risk individuals and screening for them, but the game is entirely different when you have a family history of colon cancer. So going back to the Canadian Ontario guidelines, if you have a first-degree relative, so your father or your mother, that were diagnosed at age 60 or older, you're going to start doing FIT testing, or you should, at age 45 and repeat it every 2 years through age 74. If you have a relative diagnosed before the age of 60, then screening instead of a FIT test begins with a colonoscopy, either at age 40 or 10 years before that relative's age at diagnosis, whichever comes first. So for example, if they got diagnosed at age 59, you're going to begin at age 40. If they got diagnosed at age 39, you're going to begin at age 29. And this is going to be repeated every 5 years if that colonoscopy is normal. And if it's abnormal, your gastroenterologist or the surgeon is going to make recommendations. It might be every year or two. Now, if you have 2 or more first-degree relatives diagnosed at any age, again, you're going to start screening with a colonoscopy rather than a FIT test. And again, that's going to be either at age 40 or 10 years before the youngest relative's diagnosis, whichever is the earliest. And it's going to be repeated again every 5 years. Now, what about when it comes to second-degree relatives or grandparents, aunts, uncles? Generally speaking, these are going to stay on the FIT pathway, that 45 to 74 every 2 years, unless there's other evidence to suggest that there's a familial pattern that might be more genetically related. But again, that's a conversation to have with your physician, and depending on your risk factors, which pathway makes most sense for you. Now, when it comes to the American guidelines, they're very similar. So they recommend a colonoscopy starting at age 40 or 10 years before the youngest diagnosis, again, repeated every 5 years. But these are only generalities. Ultimately, you need to speak to your physician. These numbers might differ depending on the jurisdiction. Data is always changing. So you always want to go through it in detail with your own physician who knows you. Now, just like any other rule or recommendation, there are several exceptions. There are people where routine FIT screening is not appropriate and they need to go straight to colonoscopies and specialist assessment. So these are going to be people with things like Lynch syndrome, familial polyp conditions that are hereditary, people with GI issues like ulcerative colitis, Crohn's disease that can increase the risk of colorectal cancer, people with a history of previous cancer, people that have had radiation involving the abdomen and pelvis. All these things increase risk. So just FIT testing may not be appropriate for you, and you might need to skip straight ahead to a colonoscopy. Again, something to discuss with your physician. So hopefully that was all helpful for you guys. Again, colon cancer is on the rise in younger people, unfortunately. So please, if you're in that 45 to 74 age bracket, if you have risk factors, especially if you already have symptoms, talk to your physician and either get screening if that's appropriate for you, or investigations if you're already having symptoms or you have risk factors. Like we talked about before, catching these earlier leads to better outcomes, and catching them later, unfortunately, the numbers don't look very good at all. And we'll talk more later about treatment options and things like that, and we'll have specialists on the channel to discuss all that stuff, but it's always better when you can catch these early, or ideally even prevent them, than going down that pathway. So that's it for this one. Be sure to discuss with your physician. Check out the resources and the newsletter in the description. We actually have screening checklists in our community for free to make sure that you're caught up with all the screening that you need based on the current evidence. So check that out. Let us know what you want to hear about next, and we'll see you next time. Cheers.